Cholinergic agonists. So what are the cholinergic agonists? Cholinergic agonists can be classified into two categories, like the directly acting cholinergic agonists as well as indirectly acting cholinergic agonists. So directly acting cholinergic agonists are going to bind to the cholinergic receptors directly so that they are going to produce the pharmacological actions. On the other hand, indirectly acting cholinergic agonists are going to increase the acetylcholine levels within the synaptic cleft, thereby they are going to increase the cholinergic transmission. So whenever the acetylcholine is going to be released by the exocytosis, the action of the acetylcholine is going to be limited by one of the metabolic enzymes, acetylcholine esterase enzymes. These enzymes will rapidly hydrolyze the released acetylcholine so that the cholinergic transmission can be controlled. So here the indirectly acting cholinergic agonists can inhibit the metabolism of acetylcholine by inhibiting the acetylcholine esterase enzyme, thereby they improve the acetylcholine levels within the synaptic cleft. So in this way, acetylcholine esterase inhibitors can act as the indirectly acting cholinergic agonists. So now in this video, we will go with the different types of cholinergic agonists, how they are going to act, and what are the pharmacological actions, side effects, and clinical use of all these cholinergic drugs. Before going to that, we know that acetylcholine is acting as one of the important mediator in the cholinergic system. So one of the question is that, can we use the acetylcholine as a drug? Acetylcholine is having few of the limitations to be used as a drug in our physiological system. For example, whenever the acetylcholine is given, one of the important limitation is the drug is easily metabolized. We know that acetylcholine is having a ester functionality, and this can be easily metabolized by a few of the esterases. Particularly within the plasma, we can have plasma choline esterases which will cleave the acetylcholine into the acetate and choline. So in this way, whenever acetylcholine is going to be administered into the body, it is immediately hydrolyzed by plasma choline esterases. Similarly, another limitation is that acetylcholine is not selective. That means this drug can act on both muscarinic receptors as well as the nicotinic receptors. Suppose we want the drug that is selectively acts on the muscarinic receptor, then the acetylcholine is not a good choice because it is not a selective drug and it can produce both muscarinic as well as nicotinic actions. Even acetylcholine is having few of the limitations, but still acetylcholine can be used in the ophthalmic surgery in the intraocular route of administration to produce the pupillary constriction for few seconds. Particularly in the cataract surgery, acetylcholine ophthalmic solution can be used to produce the pupillary constriction. With the exception of this little use, acetylcholine is not useful as a drug, and we should have other types of drugs which are somewhat stable and somewhat selective towards the cholinergic receptors. Now let us see the structure of this acetylcholine. So acetylcholine is made up of two important parts. So this is the acetyl group and the remaining part is the choline group. So simply acetylcholine is a combination of acetyl and choline, and it is an ester formed between the acetic acid and the choline moiety. And this acetylcholine, because it is having the ester functionality, it can be easily hydrolyzed by choline esterases. But choline esterases are two types. First one is the acetylcholine esterase enzyme. This enzyme is present within the cholinergic neurons, and whenever the acetylcholine is going to be released by exocytosis, this enzyme will cause the hydrolysis of the released acetylcholine. So this enzyme is also called as a true choline esterase, as it is going to hydrolyze the cholinergic mediator acetylcholine. On the other hand, we can have another type of choline esterase which can be called as butyl choline esterase, and this enzyme can also be called as plasma choline esterase or pseudocholine esterase. This enzyme is present within the plasma, and this enzyme can hydrolyze few of the ester compounds related to the choline. For example, this enzyme can hydrolyze the acetylcholine as well as the butyl choline. So both of these metabolic enzymes will cleave the acetylcholine at the ester functionality so that the acetylcholine is converted to acetate and choline. But when we administer the acetylcholine as a drug, acetylcholine is going to be metabolized by plasma choline esterases. So because of the action of these choline esterases, acetylcholine can be split into acetate as well as the choline. So this choline is not able to bind to the cholinergic receptors, therefore it cannot produce any pharmacological actions. In this way, the action of the acetylcholine is immediately terminated by plasma choline esterases. And now the second limitation of the acetylcholine is it is not selective towards the cholinergic receptors. Acetylcholine can act on both muscarinic receptors as well as the nicotinic receptors. Through the muscarinic receptors, acetylcholine can produce its action on few of the organs like heart as well as eye, GIT, bladder, bronchioles, and even the exocrine glands. In all of these organs, acetylcholine produces the action through the muscarinic receptors. Similarly, through the nicotinic receptors, acetylcholine can act on the skeletal muscle as well as the autonomic ganglia. And apart from these peripheral actions, acetylcholine can also produce the central actions through the muscarinic as well as nicotinic receptors. In the therapeutic point of view, which receptor action is more important? For example, if we take the skeletal muscle, which type of drugs are required that should act on the skeletal muscle? Particularly, we need the skeletal muscle relaxants which can relieve any skeletal muscle spasm, but we rarely need any skeletal muscle contracting agents. So in the therapeutic point of view, skeletal muscle relaxants are more important. But here cholinergic agonists are not producing the skeletal muscle relaxation. Skeletal muscle relaxation is produced by cholinergic antagonists. So cholinergic agonists are not having any therapeutic importance on the skeletal muscle. Similarly, if you take the case of ganglia, the ganglia is the autonomic ganglia, and when we use the ganglionic stimulants, they will stimulate both the sympathetic as well as parasympathetic system so that they produce a mixed actions. In this way, if we see that the nicotinic actions are not that much therapeutically important, but if you come to the muscarinic actions, the muscarinic actions are therapeutically more important. Particularly, cholinergic agonists can act on the organs like the eye, GIT, bladder, so that they produce few of the pharmacological actions which are important therapeutically. For example, on the eye, when the cholinergic agonists are going to act, they are going to decrease the intraocular pressure, so these drugs can be used in the treatment of glaucoma. Similarly, on the GIT and bladder, these drugs can produce the contraction so that they can be used in few of the hypotonic conditions. In this way, cholinergic agonists are more important therapeutically by their muscarinic actions compared with the nicotinic actions. So what are the drugs that are going to be included in the cholinergic agonists should more act on the muscarinic receptors. Now let us see the structural modifications to the acetylcholine so that we can produce few of the drugs which are used as the cholinergic agonists. So what is the goal in the structural modifications? By structural modifications, we have to decrease the metabolism as well as we have to increase the selectivity of the cholinergic agonists. And particularly, we have seen that the selectivity towards the muscarinic receptors is more important therapeutically. So if we see the acetylcholine structure, what are the structural modifications that brings few of the fruitful cholinergic agonists? And we have seen that one of the group is the acetyl group, which can be easily cleaved by the choline esterases. So if we are going to replace this acetyl group with an amide group, now this acetylcholine not acts as an ester, so it cannot be cleaved by choline esterases. So in this way, by replacing the acetyl group with the amide group, we can produce few of the drugs which are not easily hydrolyzed by the choline esterases. And second important modification is to increase the selectivity. So within this choline chain, you can see that this is the alpha carbon because this carbon is adjacent to the quaternary ammonium group, and this is the beta carbon. Now by substitution of the alkyl group at the alpha position, it leads to the nicotinic selective activity, and by substitution of the alkyl group at the beta position, it leads to the muscarinic selectivity. As we require the muscarinic receptor selectivity, so what are the alkyl group attached at the beta position increase the muscarinic selectivity. Now let us see the directly acting agonists. So one of the drug in the directly acting agonist is the carbachol. So already we have seen the structural modification to be done to the acetylcholine. So here you can observe that the acetyl group is going to be replaced with the amide group. Since it is having an amide group, so it is not easily hydrolyzed by the plasma choline esterases, so it is somewhat stable compared with the acetylcholine. But this drug is not selective because we cannot see any substitution on the choline chain. So this carbachol is not selective towards the muscarinic as well as nicotinic receptors, so it produces both muscarinic actions as well as the nicotinic actions. So one of the limitation of the acetylcholine is going to be removed such that this drug is not easily hydrolyzed, but still this drug is not selective. And since here we are going to replace the acetyl group with the amide, so that is nothing but the carboxamide. Within the name you can observe carba. The prefix carba indicates a carboxamide group is there in this drug. So it is a carboxamide substituted choline derivative, that is the carbachol. Similarly, another drug is the bethanechol. In bethanechol, again you can see that the acetyl group is going to be replaced with the amide group, just like in the carbachol. And apart from this structural modification, we can also observe a alkyl substitution at the beta position. So here you can observe a ethyl group attached at the beta position. So that is the bethanechol. So the name of this bethanechol is obtained from this substitution. And this drug is now not metabolized by the plasma cholinesterases, as well as this drug is selective towards the muscarinic receptors. And third type of drug is the pilocarpine. In the pilocarpine structure, you can observe one of the heterocyclic ring system, and this heterocyclic ring system is nothing but the imidazole ring. So pilocarpine is a imidazole containing cholinergic agonist. And till now we have seen the carbachol and bethanechol, which are the synthetic drugs, but pilocarpine is a natural product and it is going to be obtained from the imidazole alkaloids. So pilocarpine is coming from the Pilocarpus species, Pilocarpus jaborandi, from which we can get the pilocarpine, one of a cholinergic agonist. Similarly, another drug is cevimeline. So cevimeline is a spiro compound. You can see that one of the cyclic ring system is going to be fused with another cyclic ring system with a common carbon in between them. So such type of compounds where the two rings are going to be fused with a common carbon, they are called as spiro compounds. So cevimeline is a spiro compound, and even it is a bicyclo compound, because you can see that the 6-member ring system is again having a another bridge. So this ring is nothing but the aza bicyclooctane ring system. So this is the cevimeline, and this cevimeline is somewhat selective towards the M3 receptors. So it is a M3 selective agonist with little activity on the M1 receptors. And particularly this drug, because of its selectivity on the M3 receptors, it can increase the lacrimal as well as salivary secretions. Now let us see how these drugs going to act. We know that cholinergic receptors can be classified as muscarinic and nicotinic receptors, but here most of the drugs are selective for the muscarinic receptors. So what are the different types of muscarinic receptors? The muscarinic receptors can be classified as M1 receptors, M2 receptors, M3 receptors, as well as M4 and M5, which are more distributed in the CNS. Still the drug targets are not available on the M4 and M5. So if we see the M1, M2, M3, M1 receptors are coupled with the IP3 and diacylglycerol as the secondary messenger. These two mediators will increase the intracellular calcium levels, thereby they produce the excitation within the cell. And similarly, M2 receptors are coupled with the decrease in the cyclic AMP, and when the cyclic AMP levels are going to be decreased, they produce the inhibition. And M3 receptors, just like the M1 receptors, they are again coupled with the IP3 and diacylglycerol, and they produce excitation. M1 receptors are mainly located within the CNS as well as the gastric parietal cells. So they stimulate the CNS as well as the gastric parietal cells. So by stimulation of gastric parietal cells, they can increase the gastric acid secretion. Similarly, by stimulating the CNS, they can increase the locomotor activity, and they can also control the body temperature and can increase the memory. M2 receptors are present on the heart, and they are inhibitory in nature, thereby they decrease the rate and force of contraction of the heart. And finally, M3 receptors are present on the smooth muscle as well as the exocrine glands. So they produce the contraction of the smooth muscles as well as secretion of the exocrine glands. In this way, the cholinergic agonists can act on either M1, M2 or M3 receptors, and they can produce excitatory response on the CNS, gastric parietal cells, smooth muscles and glands, as well as inhibitory response on the heart. Now let us see the pharmacological actions. First one, the action of the cholinergic agonist on the heart. Just we have discussed that on the heart, M2 receptors are present, which are coupled with the one of the secondary messenger decrease in the cyclic AMP. M2 receptors are inhibitory in nature and they are associated with the decrease in the cyclic AMP. When the cyclic AMP is decreased, it decreases the activation of the protein kinases, thereby it produces the inhibitory response within the heart. And M2 receptors can also be coupled with the opening of the potassium channels, which produce the hyperpolarization within the cardiac membrane. So both of these systems can produce a inhibitory response on the cardiac membrane. Now cholinergic agonists can act on the heart, thereby they can decrease the rate of contraction. So since they are going to decrease the rate of contraction, these drugs can produce bradycardia as one of important side effect. And they can also decrease the force of contraction, so cardiac output is somewhat decreased. And these drugs can also block the AV conduction because the cholinergic system can decrease the atrioventricular conduction. In this way, cholinergic agonists can inhibit the heart and they mainly produce the bradycardia. And next one is the vascular smooth muscle. What is the effect of this cholinergic agonist on the vascular smooth muscle? So vascular smooth muscle means they are coupled with the M3 receptors. Normally M3 receptors are excitatory in nature. M3 receptors are going to increase the IP3 and diacylglycerol, which are excitatory in nature because they increase the calcium levels. But here the acetylcholine even act through the M3 receptors, it will not produce any excitation in the vascular smooth muscle because these M3 receptors are present not directly on the vascular smooth muscle, but they are present on the endothelium. So when these M3 receptors are going to be activated by cholinergic agonists, they produce the IP3 and diacylglycerol within the endothelium, which then release the nitric oxide. So cholinergic agonists will not produce any contraction, but they produce a relaxation by release of the nitric oxide from the endothelium. This nitric oxide can increase the cyclic GMP levels within the vascular smooth muscle, thereby it can produce the vasodilatation. In this way, cholinergic agonists can produce vasodilatory response, thereby they decrease the blood pressure, so they produce some hypotension. And cholinergic agonists can also decrease the cardiac output, as well as they can also produce vasodilatation. Because of these two effects, they can produce a fall in the arterial blood pressure, leading to hypotension. Next one is the eye. Within the eye, cholinergic agonists can affect the two types of muscles. One is the constrictor muscle. These drugs can act on the constrictor muscle, thereby they can produce the contraction of this constrictor muscle, which results in the pupillary constriction. So these drugs can produce the meiosis and the pupil size is going to be decreased. The constrictor muscle is also called as the circular muscle. For example, we can see the pupil size like this. So when these drugs are going to be acting on this circular muscle, the circular muscle can be constricted so that the pupillary size can be decreased. So these drugs are going to produce the pupillary constriction. And similarly, these drugs can also act on the ciliary muscle, and again they can produce the contraction of the ciliary muscle, which actually results in the accommodation of eye. So here they can produce the bulging of the lens, which produce the accommodation of eye. So in this way, the cholinergic agonist can produce the contraction of both constrictor muscle as well as the ciliary muscle, and because of these two actions, they can finally decrease the intraocular pressure. As the intraocular pressure is going to be decreased, the glaucoma can be treated by this cholinergic agonist. Next, let us see the effect of cholinergic agonists on the other types of smooth muscles. So cholinergic agonists can produce the contraction of the other smooth muscles. They can act on the GI smooth muscle to increase the GA motility, and they can act on the bladder to produce the bladder constriction, and they can also act on the bronchioles to produce the bronchoconstriction. Similarly, these drugs can also act on the exocrine glands, where they increase the secretions of the exocrine glands. So they can increase the lacrimal secretion, bronchial secretion, salivary secretion, and sweat secretion. The last one is not actually a cholinergic response. So sweat secretion is going to be produced by the adrenergic system. So adrenergic system can increase the sweat secretion in order to dissipate the heat produced under stressful conditions. But even it is a adrenergic response, the receptors associated with the sweat glands are the cholinergic receptors. So when we use the cholinergic agonists, they will act on these cholinergic receptors, thereby they produce the sweat secretion. Now let us see the side effects of the cholinergic agonists. So these drugs can produce the bradycardia as already we have seen that these drugs can inhibit the heart, so they can decrease the rate of contraction and they can produce the bradycardia. And similarly, by acting on the vascular smooth muscle through the nitric oxide release, they can also produce the hypotension. And diarrhea is another important side effect because they increase the GI motility, so they can produce some diarrhea. And difficulty in breathing. The cholinergic agonists produce a bronchoconstriction which may be observed as a difficulty in breathing in the treated patients. Blurred vision is another side effect because these drugs produce the pupillary constriction, so vision is going to be disturbed, leading to blurred vision. Because these drugs are going to increase the exocrine secretions, salivation is observed, and these drugs can produce a bladder constriction, thereby they can increase the frequency of urination. And finally, these drugs can also produce some nausea and vomiting as a general side effect. Clinical uses. So the first one is in the treatment of glaucoma. So glaucoma is a condition where there is an increased intraocular pressure. So these drugs, since they are going to produce the contraction of the constrictor muscle and ciliary muscle, they can decrease the intraocular pressure. So particularly drugs like pilocarpine as well as the carbachol can be used in the treatment of glaucoma. And here pilocarpine can be used in the emergency treatment of glaucoma, where it can decrease the intraocular pressure that is suddenly increased. And pilocarpine is having another advantage is that it can be used both in the open angular as well as the closed angular glaucoma. But when these drugs are given in the treatment of glaucoma, they can produce some side effects like miosis, because these drugs are going to produce a pupillary constriction. That is one of the important side effect. And they can also produce some blurred vision, as the pupils are going to be constricted, the vision may be disturbed. And they can also produce some eye pain during this pupillary constriction. And next one is the xerostomia. What is xerostomia? Xero indicates there is nothing. So xerostomia is a condition where there is a dry mouth is observed in the patients. So particularly in the cancer patients, when they are undergoing the radiation therapy for either head or neck cancer, then we can observe the dry mouth because the salivary glands are going to be inhibited. So in such conditions, we can use the drugs like the pilocarpine, which can increase the salivary secretion so that it can counteract the dry mouth after the radiation therapy. And next one is the Sjogrens syndrome. Sjogrens syndrome is just like the xerostomia, but here the salivary secretion as well as the tear secretion is also going to be decreased. So this is one of a disorder of the immune system where the salivary glands as well as the lacrimal glands are not stimulated to produce their secretions. In such situations, we can use the few of the drugs like the cevimeline. Cevimeline already we have seen it's a M3 receptor selective agonist, which can increase the salivary as well as lacrimal secretions. Next one is the bladder hypotonia. Bladder hypotonia is a condition where the contraction of the bladder is going to be reduced, which results in the urinary retention. Similarly, another condition like the megacolon, this is again one of a hypotonic condition where the motility of the colon is going to be reduced. Both of these conditions can be observed after a surgery. So in such situations, we can use few of the drugs like the bethanicol. In this way, directly acting cholinergic agonists are having few of the clinical uses. Particularly, they are used in the treatment of glaucoma, where the pilocarpine and carbachol can be given. And they can be used in the treatment of xerostomia, where the pilocarpine can be given. And they can also be used in the Sjogrens syndrome, where the cevimeline can be used.